welcome somebody most of you will know very well, Maggie Luff, who's Operations Manager for the Human Research Tissue Bank. And lots of you will know a lot about this, about tissue banking, but lots of you, I'm conscious, will never have come across what tissue banking are actually doing. And I'm hoping that Maggie, in the next half hour or so, will give us an insight into what her role is and what the Human Research Tissue Bank does. It's really poignant because we will be working much closer together as we move into a new building. We're hoping the tissue bank will come along with us and will actually be part and parcel of the whole histopathology offering while remaining as a research department. So I'm going to hand over to Maggie without further ado.
Thank you. So morning everyone, I apologise for my nasal tone. I have got hay fever. Can you all hear me all right? Can you nod? I don't think I can see anyone, that's the problem. Yeah. I'm looking at the participants and I've got a mixture here. I've got pathologists, I've got all kinds of people. So I'm not quite sure how to pitch this. So I'm very open to questions. Can we see raise hands on this? How does that work? Not sure. Anyway, I'm going to give an overview. I have winged it a bit, so there's probably areas that should be expanded. I haven't really touched on Brain Bank with the time constraints, so I can come back quite happily. I'm definitely got all my contact details at the end because I know some of you will be doing registration and specialist portfolios that may require more information, and you can come visit us because, like Colin said, we used to work really close together. We all used to be on level 5, the PATH block together. We were becoming over to the LMB. It didn't happen. We were initially disappointed, but given all the issues and extraction and drainage problems over there, I'm actually quite relieved. And the benefit to us is remaining here. We're so close to the pathologists, and actually, as you'll see, that's critical to our activity, really. So I am hoping today that I will cover what we actually do, our purpose, our staffing, who we are accountable to, who we work closely with, histology services and support we provide. So we are basically histology in a parallel universe. We are for research, but doing exactly what you guys do, and a close look at some of our activities. So our team purpose in yellow is to provide quality tissue services to meet the needs of patients and researchers. Now, I really want to be asking questions, but is anyone going to respond? Why have I put patients? Because obviously we're not a diagnostic service. I'm not receiving someone's kidney and giving them the result of that biopsy or resection. Why is this, what I'm doing and my department doing, important to patients, do you think? Is anyone going to talk to me?
If people want to unmute to talk to you, they just got to remember to mute themselves again afterwards.
But I don't know, I'd love to hear people's thoughts because I want this to be open, I want it to be interactive, and I want people to be awake.
Hello, can you hear me?
I can, hello.
Hello, I presume you're doing all of this in order to research patient conditions so you can provide better treatment for future patients?
Exactly that, yes, thank you. Who's that? I can't see who is speaking.
I'm Imi. I'm in Cyto at the moment.
Oh, well, thank you for speaking up. Well done, because yeah, I want to know you're all out there. So you're right, it's really it's a very generous role, isn't it? When that patient, so everyone signs a generic consent form or a trust procedural consent form for anything that is done to them, basically. So when they go for surgery, when they go for biopsy, they sign, they're explained of all the things that may go wrong, what it involves, and there's a little box saying consent for research, and most patients tick that. And I think that's a really philanthropic thing to do, isn't it? It's really generous. It's not going to directly benefit them, but it will benefit other people with the same condition in the future. So especially Brain Bank as well, which I was saying to Colin, I haven't had much time to put anything in about Brain Bank, so I can come back and do a separate talk. But if you think that's someone in life with a neurodegenerative condition that they're going to die of, offering their brain up to research, it's not going to help them at all. It's such a beautiful gift. And I think that's why we really need to think about the patient. We're not providing diagnostic reports, but we're respecting their wishes and upholding what they want. And therefore, we need to show integrity and respect for that tissue. So that's why it's not just about the researchers. I just really want to emphasize that. And so I've said that we facilitate research activity, and that's across the campus. So I don't know if you're all aware, there are many institutions on site. So there's Cancer Research UK, there's the MRC, various buildings, and we're all looking forward to Colin's tour around because he'll point all these out. And there's other services, so commercial, so ABCAM. So we have a relationship with them, providing tissue to them for control material. We provide control material to yourselves, so for immunohistochemistry, special stains. And we work with other trusts and other institutions nationally and internationally. So that's researchers, clinical trials, etc. Next slide. Sorry, I'm not used to this setup. So our team is very like, so again, a parallel with histopathology. We have health HCPC registered biomedical scientists, we have assistant practitioners, support workers and administrators. So a lot of research institutions don't have registered biomedical scientists, but because we are accessing patient samples and patient diagnostic archives, we want to assure yourselves as a histopathology department, when we intercept that diagnostic specimen, the researchers in terms of quality, and the patients. At the end of the day, it's all about the patients. They need to know that we are governed and working to standards, and not in some little backwater lab. We're doing things properly. So that's why we've got our registered biomedical scientists. So it's very similar setup to yourselves. But we do have a data manager because we work outside of EPIC. And I haven't really explained that on a slide, but if you think when someone consents to research, it's meant to be anonymised. It's not that, oh, Mrs. Smith's biopsy showed this, blah, blah, blah. It's anonymised, and I'll lead on to that as something else. So it's anonymised, so we give a tissue bank number. So no longer is it Mrs. Smith, no longer is it PS 21123. So that's all put into a research laboratory information management system. If we put it on EPIC, there are a lot of researchers in the trust that are also clinical. So there might be, I don't know, a clinical anaesthetist or surgeon, but they have a research arm to their role. We've got to make sure they can't unlock the key. So we work on a research LIMS. It's called Achiever Medical. It's quite onerous. It's not as user-friendly as EPIC. It's very data heavy. I'll come on to that as well. So we have a data manager who basically quality checks the work we do on there, also is involved liaising with the other user groups across the campus, because the reason this LIMS system was brought in was for traceability across the campus of tissue samples. And then we also have a research nurse, and that's for the brain bank side, which, like I said, we might have to talk about another day. There's myself as an ops manager, overarching both brain bank and tissue bank. Acronyms are a bit interchangeable, so people talk about tissue bank, and our actual title is Human Research Tissue Bank, which doesn't roll off the tongue. 16 staff in there, and brain bank is very small, 4 staff. What I haven't talked about actually is our clinical leads. I'll edit that. So Dr. Jimena Linan, so Merche, is our clinical lead for tissue bank, and Kieran Allison is the lead for brain bank. So that again gives some accountability. We're not just going off on our own. There's a medically trained person that is answerable and accountable, and that can be escalated up if necessary. Everything needs to be visible and transparent, doesn't it? We don't want to be giving away human tissue to the wrong people. All my staff are paid on the payroll for CUH, but we're funded by Biomedical Research Council or other research programs. So some posts are actually fixed term. So myself, I'm on a fixed term contract for a project out of CR UK. So it's quite interesting, but in terms of staff retention, sometimes quite difficult, because obviously it's harder to attract people sometimes to a non-permanent post. But bearing in mind the NHS is a very good employer, and after 2 years, you know, they don't want to make you redundant. You have rights as an employer, and so if funding can't be found, alternative employment will be found. But at the end of the day, we've invested in those staff, they've invested in us. We want to keep our guys, so we do our very best. So governance I've touched on, because obviously we're dealing with human tissue samples. So who can tell me about the Human Tissue Act? What is it? Someone that's doing their portfolio that needs to answer this. We're getting no answers. You need to know it for your registration. Go on, someone. No takers. So it's law, isn't it? An act is raised as law, and it's governing the use of human tissue, and that's counted as relevant material. So it's basically illegal if you don't abide by those laws and standards. So all research activity on the campus comes under the research license, which has a number. And then we also are affected by the post-mortem license, because obviously a brain donation has to come from someone who has died, so that's post-mortem. Those license holders are in the trust. So Merche is the research license holder, but stepping down, and post-mortem is Beth Haynes. So they, if anyone breaches, they could end up going to jail. Basically, it's that serious. So the governance is massive, and it's accountability and traceability of the use of human tissue. So consent has to be given for the use of tissue for research, and it has to be anonymised unless you've got study specific, which may allow more information to be given. But also to add, because we are accessing diagnostic tissue, so the samples that would come to histopathology, and because we're accessing your archives, so your blocks, your slides, we also report to pathology. So I kind of report in lots of directions because of my funding, because of pathology, because of HCPC, but yeah, it's to assure people we're doing the right things. We don't work to 15189 because that's clinical laboratory ISO, which is what Histo work towards or have got. We're working towards biobanking, which is more applicable to what we do. But obviously anything that we do relating to histopathology, so when we book in a diagnostic specimen, we follow your SOP because that is going on the UCAS accredited 15189 pathway. So I think I already mentioned that we're funded by BRC, which is the Biomedical Research Centre. So currently there's just been a cycle of renewal of that funding. So we're kind of in limbo at the minute. We're waiting to see how much funding Cambridge will get. There were sites across the country of BRCs. I know that Cambridge will get funding, and I think that was announced on the 16th, but we don't know ourselves exactly how much we'll get and how much that will impact, because as for everyone, the cost of consumables has gone up, the cost of services has gone up. And like histopathology, to do the techniques we're doing, it's all very manual, it's all hands-on. We need staff. I can't get the work done without pairs of hands. So that's something I'm trying to get across in terms of funding, but we're waiting for that allocation. Because of the nature of us being infrastructure for the Biomedical Research Centre, I actually report to Research and Development Finance and Research and Development HR, so that is slightly different to Histo. So we work very closely with yourselves. Obviously we're a little bit distanced now, but we go to theatres and we pick up samples. And I've said that we get them directly from theatres. Why do you think we go and fetch those samples? Why don't we wait for someone to bring it to us? Come on, someone, please have a go at answering that. I mean, I've sort of said it there, sample integrity. So a lot of samples, the research nowadays is molecular based. It's DNA, RNA. If you leave a sample sitting around in a warm theatre, it will degrade. And so many tests now, it's all about translational research, isn't it? It's what's being done in the research lab and it goes straight to the patient. It's having an impact. It's making a change to their treatment. So translational medicine is all key at the minute. So we identify the patients that we need to collect from, and that might be because of a particular research team. So we've got a group called OVO4 who are interested in ovarian cancers. So they'll say, please look out for patient X, patient Y. So we check on the theatre list on Epic Status Board and we identify for that day. So today we build a list of the 2 ovarian cancer patients. We might select a colon patient, put those on our list. And then when we keep monitoring, and then the theatres ring us and say it's ready to collect. I mean, it's difficult, isn't it? The theatre staff are there to look after the patient. They're bothered about their recovery. But for us, the priority is the sample. So it's a fine line, and we do what we can to interact and get it as soon as possible. So I've just highlighted consent for research because that's fundamental. And I've also highlighted surplus to diagnosis, because what we cannot do is have a specimen and compromise someone's diagnosis. And I think that's the reason really that tissue banks were set up. What you don't want is a researcher in theatre taking what they want, or a surgeon aiding that, saying, oh yeah, you can have a bit of this, because it's opening a specimen, for example, which might affect resection margins and orientation and compromise diagnosis. So it's much better for us to bring the sample here. It's to be seen macroscopically, so that's either by a pathologist or a suitably trained biomedical scientist. We take the measurements, we describe it, take photos if necessary, open it, sample it, having assessed how much material there is for diagnosis. That is paramount. We cannot compromise that. And there's times we have to say to the researcher, we couldn't collect today. It was all required for diagnosis. What was one thing I was going to say? So that will explain when you get forms and cut up little scribbles on them that will give you a little macro measurement. So the uterus, give you the measurements of those, and opened and fixed by, and a date and a TB number. That's us. And if you don't understand what it is, or there's a mistake with it, please let us know. You know, we need to review our mistakes. We need to not impede the diagnostic process. So do feedback straight away. The majority of cases we collect are cancer resections. We do try and support other research, but the Trust predominantly as a research centre, I mean, it's the most significant disease, isn't it, cancer? So that's what we're here to support. But we are demand driven. So this is another problem. We can't predict how many staff we need in 2 years' time, because we don't know what the next big thing is, or the next big research project is going to be. We literally supply what is requested. So I've said about working closely with theatres, and then the many people and teams on site. So we do a lot of work with the Precision Breast Cancer Institute. They've just changed their name, so I have to write that down. There's a big programme called the Personalised Breast Cancer Programme. We do a lot of work for those. That's biopsies that are taken in theatre. And these are patients who, I think these are the triple negative patients, I could be wrong, but they won't respond to Herceptin, they won't respond to tamoxifen, but they've proactively signed up to the research programme because actually they've been offered novel therapies, and actually it's really benefited some people, it's prolonged their survival. So, you know, it is benefiting directly, this research. So it's quite exciting, and we really, you know, it makes us feel, sometimes we don't feel like we're contributing, but with that program it's real, it helps, and we get really good feedback from that team. So our core services, this is basically a list like histopathology, isn't it? You know, we do tissue processing, we cut frozen sections, we cut paraffin sections, we stain them with H&E. Immunohistochemistry, we do tend to, if it's an antibody supplied by diagnostic histopathology, there's no point us working in a silo and buying an antibody for one project that, you know, bottle costs £200 and then we just do 20 slides. It doesn't make sense to do something in parallel when it's already running as a diagnostic test. We understand that obviously diagnosis comes first, so we feed that in, and Eliana will manage and triage that work. But yeah, so there's a sharing of resource there. We do digital slide scanning, not on the scale that yourselves will be doing it, but we have done that for a long time for teaching purposes, for publications, for big trials. We've got a huge trial coming up, inflammatory bowel disease, where we want to retrieve a lot of slides, the index biopsy, and it's going to be multi-centre, so that's quite exciting. I was hoping that your slide scanning would be up and running by then, but it's fine, we can do it. Clinical trials, so that's, oh sorry, there are tons and tons where they may just want a block retrieving, so that is still done properly though. So we'll access the diagnostic archive, we will check with the reporting pathologist that that material is no longer required, or there's no ongoing tests, because nowadays, even though a report has been sent out, it might be there's follow-up molecular testing required, so we seek permission from the relevant pathologist. Obviously if that pathologist left, then it's the lead speciality pathologist, and we'll document on Epic that that block has been sent away. So it's all just paper trail. We have a lot of paper. So I think it's interesting, when people worked with us over here, there might have been a perception, oh, tissue bank, just stand around, wait for specimens. What do they do? We do a lot of sitting at computers, because the documentation and the trail and traceability of these samples, it's not a standard pathway. histopathology, you get your specimen, you fix it, you dissect it. We have very bespoke requests. I'll come on to that. Tissue microarrays, I don't know if anyone's come across that in their specialist portfolios. So that's basically preparing a block with samples of different patients, really. So your H&E control is a microarray because it's got, is it 3 or 4 tissue types in? So that's a small microarray. It's giving you a selection of tissues to check the H&E staining. Well, a microarray for research could be 100 samples from 100 patients, because then they could throw a research antibody or do an in situ hybridizing test or a molecular test, and it's saving reagent, it's allowing comparison. So that's something we can build. Cambridge Brain Bank, I will come back to on another day, I think, but it's very different. It's still involving histology technique. There's a whole brain, which is tissue, obviously, half of which is frozen. I know Nikki's on. Maybe I should get Nikki to do it. Half is frozen and half is fixed in formalin. A report, in the sense, is generated just so that there's confirmation of the disease. So it's characterizing what the tissue is, so that when a researcher applies for that tissue, they know what it is. So there's always a basic workload of every donation has to be typed, as in reported, characterized, but then there'll be requests for different parts of brain tissue, fixed or frozen. So daily activities for Tissue Bank is the collecting the fresh samples, and we use a lot of nitrogen and we use a lot of dry ice. So they've all gone up in price, and obviously there's the inherent health and safety risks of handling those. And during COVID, we always felt quite safe because we had our safety cabinets. Everything we do is done in a microbiological safety cabinet because it's fresh tissue, therefore it's infection risk. So we distanced ourselves, but we didn't really have to change practice too much because we were always working in a safety cabinet. So yeah, majority of tissue is frozen because that's kind of the gold standard in terms of integrity of DNA and RNA. But many researchers might have tissue in media or formalin, but frozen, at least you can take it off into fixation and processing later on, but if you freeze. And then we store in -H freezers. I don't know if people have come across those. So where the histopathology freezer is currently in freezer room 1, we've got several in there. That freezer room went to 34 degrees May bank holiday, which wasn't great for all those freezers. They were working really hard. So it's protecting the integrity of the samples, and they're all under HTA governance. So it's secure room, so secure, you've got a keypad and a swipe card, haven't you? But yeah, it needs to be kept cold, so those freezers are reliable and a continuity of preservation of that tissue. And then yeah, so if we've got a sample for the histopathology pathway, we'll have sampled using a pathologist or one of our trained biomedical scientists, and then that's put in formalin and sent to yourselves. So sometimes we're helping you because we're opening a specimen, which is aiding fixation. I'm afraid during COVID we didn't. We just didn't collect anything fresh. And then I just wanted to talk about daily. So you can't plan a day in Tissue Bank. You know that you've got a list of patients. Some days it might only be 6. It's not many compared to histopathology, but you don't know when that's going to be. You know when they are in the list, but so someone who's going for a gynecology resection, you can't put a timeline on it because each patient is different. There might be scarring from the actual disease process. There might be not as slim as another patient. It might be difficult, just general procedure. So researchers sometimes say, oh, what time will that sample be? And you cannot give a time because it's so dependent on how the surgery goes. We do have a cut-off, so our day is slightly longer than the standard histo day. We work until 6 p.m, and that's trying to capture as many samples from theatre as possible. But anything after 6, we just have to say put into formalin. But so we're determined by those. So we don't know when they're going to be. We know sometimes in the day theatre will ring and someone has to go fetch that immediately, and then a biomedical scientist assists the pathologist in dealing with it. So that kind of interrupts what they're doing. In the meantime, they're doing a research request, which could be from any group and could be for any kind of material. So some places ask for untamed sections on coated slides because they're going to do downstream techniques that need those sections to stay on. Other groups might ask for unstained sections on normal slides because they're going to actually scrape off certain areas for extraction. And so each day is different, each request is bespoke, and actually we enjoy that. It's different, it's variable, sometimes irritating because you'd start something and you can't finish it. And so we use something called a progress sheet, because, you know, X person might have started something on Monday and then there's a really heavy work list from theatres, they didn't actually finish it. So at least if they're off on Tuesday, someone can pick that up and follow. So we are paper-based, unfortunately, because it's, like I say, non-standard. One good thing with that, though, if you're given a task, you finish the whole task. And I know it's not a criticism, but in histopathology, just because of economies of scale, you work in cut-up, you work in the main lab cutting sections, or you're in immuno, so you're part of a huge process. And I just worry sometimes that it's easier to lose sight of the patient, whereas without, or the request, whereas ours, you know, you're given a request and you're seeing it through from start to end, and that's quite satisfying. And you tick your box and you have closure because you've done it. One thing that takes a long time is slide and block retrieval. So any of you out there that's had to file blocks and slides or retrieve, I mean, I know we have an archive team now. For us, it's pretty onerous. I mean, we have research requests and it's hundreds of glass slides. And we try and explain to the researchers, I don't think they can actually visualize it in their head. Sometimes we send a photo to say, look, this is a lot of glass. You know, to them, it's just a patient. I don't think they've appreciated that for gynae cases is on average 20 slides per patient. And each one of those cases, you have to put in a paper tracer. So it's quite an archaic system, but it works. But it's time sensitive and time involving. Requesting from CELNAS in Wales all takes time. You could do it electronically, but you still got to look, is it there? Yes, right, I'll request that. You've got to receive it. You've got to say you've received it. You've got to update EPIC. So it's, yeah. And data entry. So I talked about Achiever Medical. So that's our limbs, the research limbs. So your patient is a donor. I've just noticed I put form instead of from. And so every single thing generated from that donor. So then you'll have a collection event, which might be their operation and, I don't know, uterus. So then we'll take a fresh sample. So that has to be marked on there. So we'll have a fresh sample tumour, fresh sample normal. If we have another patient that's having just unstained sections cut, every single unstained section is put on there. So I feel like it's probably more detailed than even EPIC, and it all takes time. And actually, although we've got a data manager who oversees changes in the limbs and checks the quality of the data put onto the limbs, we kind of need a data handler, and then it would release to our medical scientists to spend more time on doing the actual science work, the hands-on work. Sorry, next slide. So I'd already mentioned about the tissue microarray machine, and that's our slide scanner, so it looks very different to yours. This has got 400 slide capacity, and I don't know with histo, I think it probably goes straight from staining, well, dry the slides and then scan them. So the issue for us is generally their slides out of the archive, so they need cleaning, you know, which just sounds easy, but it again all takes time. It's the slide preparation, cleaning them to get those good quality images, and anonymizing them as well. Eventually, I think we'll be part of the big system. And I just wanted to emphasize that today's research is tomorrow's diagnostic test or treatment, and just give examples of the big projects that Tissue Bank has been involved with that are now actual diagnostic tests. So we supported the 100,000 Genome Project, which has now led to whole genome sequencing, which is going to be rolled out to all cancer patients, but it's currently just the paediatric and sarcoma cohorts. And that's collecting samples from resection specimens or diagnostic biopsies, actually freezing them, cutting frozen sections, and then staining them, and then getting them assessed for their tumour content and cellularity. So it was a lot of work and a lot of samples, and all had to be documented, probably too much information really, because then that all had to be collated by NHS England to look at those data sets, to come up with a proposed solution for the diagnostic pathway, which we're still working through and supporting and handing over to Histo. And then the other big significant project that you may or may not have heard of, so Professor Rebecca Fitzgerald, so she's just got an OBE for all her work in early detection, basically, so early cancer detection, and quite rightly so. But Tissue Bank have been involved right from the very beginning with the cytosponge, which is a big, horrible capsule to swallow, but actually it's an alternative to an invasive endoscopy. So in terms of patient comfort, in terms of cost, time, it can be done in the GP surgery rather than coming into a hospital, so it's much better for remote areas. So it's swallowing a big capsule, which you leave for a certain amount of time, the capsule dissolves, and then they pull out a sponge, which dislodges some cells. So it's basically a cytology test, and that's looking for precancer or Barrett's esophagus. And so we did loads of work, so there was BEST 2, BEST 3, and now that those sponges are out with a different company, Cyted, doing analysis and reporting, but we were key in that research, and it was quite satisfying for the guys involved. So really feedback to Histo is, one, you know, get to know us. We're normal, we're like you, we're doing the same things as you, just for research, but sometimes obviously we make mistakes, but let us know, and let us know straight away. If we've not documented something correctly on a diagnostic form, you know, we do respect that a diagnostic sample mustn't be compromised, so we need to learn from that. If a histo procedure has changed, we also need to know that. I know when the block cassette colours changed, we didn't know straight away, and so we were using the wrong colour. So please communicate with us. Obviously, when we're working much closer physically, that will hopefully help that. A big thing at the minute, so neurosurgical samples, so samples from neurotheatres that are received at histo reception and go to neuropathology. We've had quite a few cases recently where the tissue sample and bloods aren't labelled correctly. Don't accept them, please don't accept them. It's much better to notice that at reception and get them sent back straight away for relabelling or labelling. If you accept them, it's much harder for everyone because it's kind of with you or us, and harder to address. I mean, at the end of the day, I don't know if sometimes people think research samples aren't important, but they are. It's still the patient has consented to willingly donating some tissue for research, so it still needs to be respected and treated as such. And then I should have put a picture in, really. I'll add that for the notes. So some of you will have seen the surgical paraffin block request for tissue in cut up. So you'll get some blue cassettes and a piece of paper. And that's basically, we have sampled that tissue, we've taken frozen during fresh cut up, and we'd like mirror image blocks, really, or equivalent of formalin fixed paraffin embedded material. But again, it's not our place to do that. It's also easier to sample once it is fixed, and it's down to the cut up pathologist or AP to do that. But as someone assisting, if you could make sure that if we gave you 4 cassettes and you only use 2, then just dispose of 2, but record the 2 that have been taken. We just need accurate information, like you're doing for your normal blood sampling records for diagnosis. It's the same for us, please, so that we know what's been taken, so we can update our limbs. I have kind of whistle stopped. What time is it? Oh, okay, just over half an hour. I mean, any questions, then email or ask now. Anyone who is doing registration portfolio needs to know more about consent and HTA and things relevant to the portfolio, please come visit us. You're very welcome. We can arrange a time. I'm sure that'll be supportive on the histopathology side. Yeah, and I will do something about brain bank, promise, another time.
Thank you, Maggie. Thanks very much. Anybody can put any questions in the chat room if they want. I think lots of you will have been given some food for thought as to what the tissue bank does. Maggie, just from my point of view, the importance of having tissue which has got a good clinical diagnosis and good pathology annotation. What's the importance of that for researchers? I know you've mentioned it, but just to highlight what that really means for researchers in drug discovery and biotech.
No, and the good point about that, Colin, is so Achiever Medical as a LIMS, is not that helpful. It's fantastic for traceability of tissue, but it has no clinical information. There's no interface between EPIC and Achiever Medical. And that's something we really need to push for, and is being pushed for. I don't know the timeline for it. Previously with the legacy database, someone used to copy paste the final diagnosis into the database, and we don't have that information. So actually, if someone says to us, oh, please can we have 10 cases of hepatocellular carcinoma, we can't do it. We can't do it on the current cases, which is pretty embarrassing, isn't it? So we have to go to EPIC, do a search there, and then see if any of that resulting cohort have tissue bank material, which is quite clunky, isn't it?
Very, and that's quite embarrassing if we can't do that, because that's its value really, isn't it?
Yeah, the power is not there. And as a manager, I want to know my workload. And again, you can't do that on Achiever Medical, because there are so many different users of Achiever Medical. So we'll release something to the molecular diagnostics lab, or it'll go to CR UK, and so it would count their material as well. It can't, there's no hard stop when it's finished with us. So in terms of that kind of data, it's not great.
Okay, are there any moves to do anything about interfacing with EPIC?
So AFCEL is where the clinical, so we've got clinical informatics is a tiny team supporting Achiever Medical, and actually got a meeting next week, because in terms of the governance of Achiever Medical, and everyone using it in the same way, and ensuring that you don't release tissue on expired ethics. I didn't even talk about ethics, did I? There's a whole thing about that. So basically, the trust needs to invest in a governance team for the research compliance. We've got Bev Haynes as HJA compliance, and it's not well funded. She still sits on my budget. There needs to be recognition that this campus wouldn't exist, the research wouldn't exist if there was a proper, if we lost the license. And so they need to really take it seriously, what is being done under that license and how it's managed.
Okay, thank you. Any further questions? I think we'll have given some of you a bit of food for thought, and I just repeat what Maggie's just said, that, you know, we want to start working much closer together. We already do, a lot of us, and Maggie and I have lots of chats with, as does Jenny and Zara with Maggie, and that's where we're heading in the future.
And I didn't say, because those of you that don't know me, I used to work in histo until 2015. I should have said that at the beginning, really. So yeah, I understand. I know what goes on. Yeah. It's good for me. I see both sides. And actually, one of my interview questions was, how would you feel about, you know, you're not contributing to a patient diagnostic report? And actually, it doesn't matter, because we are still contributing, and that's what I've been banging on about, is that we're honouring a patient's wishes, and we are contributing to the diagnosis of the future. So yeah, it's still valuable, and we all still feel worthy in that sense.
Okay. No further questions? Okay, thank you very much, Maggie. Much appreciated, and I'm sure some people will be thinking about it and approach you afterwards. She is very approachable, by the way.
My door's always open, Anna. All right.
Okay, thank you very much.
Shall I say where I am? So it's literally on the right. It's the noisy office. All right.
Okay, thank you very much indeed.
Take care. Bye.
Thanks, bye.